All right, welcome guys to chapter 14. We're going to go through talking about the different disorders. And I think this is a really great chapter. One of the important things that we're going to pull from this chapter is really just understanding the concept of what are some different mental health disorders, why we diagnose, and then on top of that, one of the really cool things that we're going to get to do is explore kind of some of the justifications and concepts behind the idea of diagnosis. Should we diagnose when we don't diagnose, and how we kind of split the differences between some of these different really kind of interesting mental health conditions. And so let's get started. Okay, so jumping in here, the first step I think often is just defining what does it mean for something to be abnormal, whether it's a behavior that's abnormal, a thinking pattern that's abnormal. But in order for something to be a disorder, it needs to be kind of an abnormality, or at least something that is needs to be addressed. And so one of the things I often just ask the class when I have a live class is to say, well, what does it mean to be abnormal? And we start off with like, well, maybe just something that's unusual. And I say, okay, so if you act unusually, does that mean you need to be diagnosed? Is that a disorder to just kind of act in a different way than someone else? And it's like, well, no, not necessarily. And so we go beyond just this kind of atypical type of behavior, but this idea of is it justified? So for example, if I have someone presenting in my office and they're talking to me about feeling down, they're crying, they're not sleeping, they really kind of don't have a lot of motivation, and it seems pretty close to almost this depression diagnosis. But then I look for justification, like, so is there anything that happened recently, any changes? And all of a sudden they're telling me about the loss of a loved one or a wife, and it's like, okay, so this isn't so much a disorder as it is kind of this adjustment to the loss of a loved one. So understanding that circumstance justification really needs to be kind of an important key piece here. Is that if there is or is not a justification, as well, how much time has that presented? And is it getting to the point of maladaptive, right? So in other words, if someone's feeling down on a day and there's not really justification, you might kind of lean more towards that depressive. But have they been down for just a day or 2 days? At some point we kind of set a timeline. If we're really kind of having those depressive symptoms for at least a couple weeks, that seems to last, and we're not having these days where we just feel fine and there's no issues, whatever, but it's kind of pervasive, continuing to happen. And in the same way, when we kind of talk about these kind of maladaptive behaviors, again, if we are having kind of some bereavement, grief, the loss of a loved one, and those things, sometimes those behaviors can be somewhat adaptive, and sometimes they can be maladaptive. If that person is, we have an extreme severity of symptoms. Again, we can't tell somebody you can only grieve this long, but let's say that person has been grieving for a prolonged period of time, and now it's starting to take away from their social interests, take away from their ability to do things like feed themselves, dress themselves, be able to go to work, be able to take care of other needs. I mean, we have to kind of really consider like this type of behavior now is become more and more maladaptive. Not only maladaptive to the person, but also to the people around them. And we'll talk about that later when we get into things like personality disorders. But again, I think really kind of an interesting discussion, and I think a discussion worth having. All right, let's move on to the next slide here. So just like with everything else, we do that biopsychosocial approach. We're going to go through the biomedical perspective, psychoanalytic perspective, behavioral, and cognitive perspectives. Each of these kind of giving their own position on these different kind of mental health disorders, how they come about, and what things, what things kind of keep them going, if you will. So. Getting into the kind of biometric perspective, again, if we use like something like alcohol use disorder as a vehicle to have these conversations, We can begin just with some very easy pieces. Like if we have a hormonal imbalance, like our thyroid is either underproducing or overproducing, that can cause either kind of depressive or anxiety related symptoms. And as a result of those symptoms, then now we're going to start to look for things to kind of manage um, those those symptoms. Sometimes we'll use something like alcohol to kind of numb that overwhelming struggle, or that overwhelming feeling of depression. Chemical and electrical imbalances. If we look at something like where we have a pretty kind of intense case of like bipolar disorder, we do see kind of a chemical change and some of those things, and as a result, that does change that person's mood dysregulation, and as a result, sometimes people will use something like alcohol to help them. Brain injury is another very common area. If we have a part of the brain that is damaged, that may reduce inhibitions. It may kind of increase, symptoms of different types of mental health issues, to where that person is seeking out something like alcohol or another substance. And so, if you're looking just strictly from a biomedical perspective, you would then say that most substance use disorders are just kind of somewhat kind of derived from a hormonal imbalance or brain injury, some type of chemical deficiency, or even looking at kind of genetic predispositions, where we do see that if we have a family member that previously had struggled with alcohol use disorder, that they may have passed down kind of a increased sensitivity again toward that. But again, that's just one picture, one piece of this. If we look at this next piece, psychodynamic perspectives, what we see here is understanding something like, again, substance use disorder, alcohol use disorder, through the lens of kind of early life polarizing events, traumatic events in early life and how they impact our later life. Looking at research studies of women entering treatment programs for drug and alcohol abuse, over 75% of women had reported in the study being sexually abused in their early life. And so at 75%, it's a large percentage. It's not just saying, well, some people who are in a substance use or alcohol use program had been sexually abused, but 75% showing us that there's something more here than just a biological perspective, right? If we go into the next study here, nearly 90% of women who have become dependent upon alcohol suffered severe violence at the hand of a parent or were sexually abused in childhood. Okay, wait a second. Now we're seeing that social impact, those early traumas, kind of playing a much bigger and bigger role, right? So oftentimes I might hear someone say, well, they're just a weak-minded person. They're not someone, that person just doesn't want to quit, or that person's not really trying. And I go, so what do you say to these numbers? Like, what is that? Is that, oh, they're just all weak-minded people? Or is it that these experiences really do have a greater impact on us than we think? A study of 100 adult patients entering a polytoxic drug abuse program revealed that 70% of the female subject had been sexually abused prior to the age of 16. Again, just showing us over and over again that there's something to these kind of early life traumas, and we need to dig a little bit deeper to understand the person. Oftentimes substance use is a masking thing, right? We're trying to mask something else we're feeling, some type of pain or trauma. Behavioral perspectives are going to look at the idea of substance use simply through the lens of observational learning, right? We are around kind of other people, we're around our parents, we're around our family members, and we watch how they act and interact in their lifetime, right? If they have a stressful event, we watch and see how they deal with it. Do they talk through it? Do they kind of hide from it? Do they use something like alcohol or some other substance to kind of deal with it? How do they go through their day-to-day life whenever they're feeling down, feeling happy. How do they celebrate that? Again, we're constantly watching and learning from the people around us, and not only the direct people around us, but also through things like television programming and other sources. Right, so we're constantly learning behaviors, and again, we can learn functional and dysfunctional behaviors just by kind of being around it. And just like I've said before in the class, one of the things that we find is that you don't have to be the one directly affected by something in order for you to learn from it, right? I could take a marker in my class, and someone asks a question. I could peg them in the head with a marker, and you go, oh, maybe I shouldn't ask questions, right? Like, you don't have to get pegged in the head with a marker to know probably I shouldn't ask questions. You know what I mean? Something like that. It's just kind of this idea that we're always picking up information from our outside world. The cognitive perspective is looking at this thinking patterns, right? The way that we kind of review different events in our mind. If we have a negative experience, something happened, we didn't get an outcome we expected when we, let's say, applied for a job. Then we have this self-focus, self-blame kind of thought process that comes in. Things like, oh, I'm not as good as someone else. Like, I'll never find a job. I always fail at everything. And when we have that kind of thought process, well, that naturally kind of leads into a depressed mood. And with depressed mood, we have kind of a lessening in the interest of interacting with other people. We have kind of a lessening in our motivation and our physical activity. We just kind of see a lot of these things kind of come with that depressed mood, those behaviors as a result. And then therefore we kind of get into this cyclical pattern where now we're kind of then having more negative experiences because we're pushing people away. Then we feel alone. When we feel alone, why do I feel alone? Why am I alone? Well, again, negative self-thoughts, negative perspective. Well, I'm a failure. I haven't accomplished these things. And again, it just kind of goes through and through these patterns of thought process. And that can really impact, that person's life, quality of life pretty significantly. So bringing these together through the biopsychosocial approach, we are trying to realize that, just like a meteorologist, we have to bring all the little bits and information pieces together to really kind of start to get a bigger clue of what that picture looks like as all those puzzle pieces come together. And now we can understand, what is the driving force behind what's happening here, biologically, socially, learned factors, social kind of cognitive reserves, and how people handle those issues or problems. Now, when it comes to this kind of model, how we address mental health symptoms and then the diagnoses, one of the things that the field of psychology, or just even mental health in general, has kind of run into is this trying to find a way to emulate a science that seems to be a lot more structured or standardized. So if we look at medical practices, right, the medical model, this idea that all kind of diseases have a physical cause, they can be diagnosed, they can be treated, and often they're cured, and that's really a hard method to kind of put onto the mental health field, right? Like, if you think about, like, well, if someone's struggling with depression, or someone's struggling with kind of an anxiety disorder, this idea that has to have a physical cause, like, it doesn't always make sense. It doesn't always relate. There isn't always that cause. And then also this idea of treatment and cured, that sometimes that's not really the goal. The perspective is that we get those symptoms into a manageable area, and that person may kind of have some kind of remissions, and then going back into kind of a cycle where those symptoms are more present in their life, but it's not necessarily, it doesn't line up exactly with the medical model. And so that's also been kind of a difficulty in the mental health field, is really kind of finding a good way to kind of put ourselves in the same kind of mm, acceptance as something like the medical field, right? We can talk about something like diabetes or heart disease or hypertension, high blood pressure, those kind of things, pretty easily. It's not like something we have to worry about. Is someone going to get upset if we talk about this topic? But you start talking about something in the mental health field, and there's almost like this kind of hushing, like, oh, I don't need to share that too much. I got to keep that to myself. What is someone else going to think if I tell them that I might struggle with this or that? And that really, again, has just been another thing that's kind of held the field back. Now, we've kind of talked a little bit about like personality in the last chapter, and we talked about kind of how, different viewpoints on personality, trying to understand all the kind of idioms to describe different people's personality. You run into a problem where now there's so many words to describe something, you don't have a common language. And the same kind of thing here with the field of mental health. It was important to create a common language to describe, like, when I say someone's struggling with like single episode unipolar depression, I want someone else to know exactly what I meant by saying that. If I told someone, patient is struggling with bipolar 1 disorder versus bipolar 2 disorder, like, I need the other person, whoever else might see this patient, to understand what I'm trying to tell them. And so we created these different terms for these different mental health disorders. Then we break down what symptoms should be present in those specific mental health disorders. And then from there, once we kind of identify that pretty clearly, then we can all kind of come together to the same place, understanding that we're probably seeing the same symptomology. And as a result, we can create a treatment plan that helps that person as best as we can. And this diagnostic and statistical manual, the DSM, that we've created has gone through many iterations so far. We've had revisions after revisions. The DSM is on the 5th version of it, the DSM-5, but again, this is DSM 5.7. Like, we're constantly adding or changing the diagnostic criteria. Sometimes we're taking out a diagnostic category altogether, and then or moving that into a different placement. So let's just kind of look at the DSM-4. Now, again, we're not in the DSM-4 anymore, but this is just to kind of show you categorically how different disorders are placed. We begin with things like the anxiety disorder category, which is one of our biggest categories, and then we have our, like I said, with the biggest category, we have everything from like phobic disorders to generalized anxiety, obsessive compulsive, like lots of post-traumatic, lots of different kind of mental health disorders fall in that category. And then we have things like our mood disorders, like depression and bipolar disorder, and mood dysregulation disorders as well. Somatoform disorders, again, if we break down the word somatoform, so soma is that first word part, soma meaning body, and form meaning the form of the body. So a somatoform disorder is kind of this idea that there's something, either is something wrong with my body, or I don't feel like part of me is feels right or looks right. And so, with the somatoform disorder, we have things like hypochondriasis, or hypochondriac is probably a term you've heard, where someone is kind of feeling some type of physical sensation in their body, and then they they become overstimulated by it, and so now they think there must be something wrong, and they start kind of really feeding into that, and that can become a very unhealthy disorder. Moving into things like are kind of psychotic disorders and schizophrenia. There's different types of schizophrenia, and we'll get to dive deeper later, but personality disorders, sexual disorders, substance-related disorders, dementia. And what's really interesting is that at one point in the field of psychology, we actually broke down, we separated, we had medical disorders, And then in a separate category, we had mental health disorders, right? That's a whole different category. And then we had a third category, which we said was the personality disorders, right? So that was almost its own thing. It's totally separate. And since then, we've actually kind of merged the mental health and personality disorders into one category because we're like, hey, they're all kind of mental health disorders. We don't need to separate as if there's something completely different. As well as we've also kind of pushed to merge our mental health disorders into the physical health disorder category. So instead of saying, well, is this physical or is this mental? It's like, wait a second, it impacts the brain and the body. There's that brain body interaction. So it is actually all kind of in the same category. It is all disorder. Whether it's, someone struggling with diabetes or if someone's struggling with moderate recurrent depression. That for some reason doesn't, we don't have to separate. We can just put them right there next to each other and show that these two things are disorders that happen within the person. And that's really kind of helped us to, as well, kind of have a little bit more of a commonplace, not only within the medical field, but also having much more commonplace within the homes of people, being able to talk about these different disorders in the same way that we might talk about another kind of just medical or mental health or physical disorder. Now, we really wanted to kind of search out what were some of the benefits and some of the drawbacks when we create something like a diagnostic and statistical manual, trying to label someone, with a mental health disorder. Does it really impact the way other people view them? Well, David Rosenthal, and some of his colleagues decided that they wanted to really explore this. So what they did is they purposefully admitted themselves into a psychiatric inpatient facility, right? So in other words, they were taken to like a place like for us the Pavilion, and there they presented purposefully, pretending to present with symptoms of like schizophrenia and mania and just very psychotic presenting symptoms. And then once they were brought into the facility, once they were diagnosed with schizophrenia or whatever diagnosis they were given, then they would just act like their normal selves while they were there. They would, get up and read the newspaper, or they would come and attend the groups, or they would, just kind of go about their day without presenting any of the psychotic symptoms that they came in with. And they just want to see how did that impact the way that everyone else viewed them based on the diagnosis that was placed on their chart when they came in. And it actually became very interesting because as a result of people seeing that they had this specific diagnosis in their chart, they started observing their behaviors in different ways. So if one of them was sitting there reading the newspaper and they were just kind of reading along, then they go, oh, that person's fixated on the news and they're over obsessing about this or that, or if someone, one of them came out of their room to attend a group and, oh my gosh, I forgot my notebook. They went back to get their notebook and they go, oh, well, disorganized thinking, the inability to kind of accomplish daily tasks, like all of a sudden something, like there was something weird about this very kind of normal behaviors. And so even in the mental health field, we find that sometimes if we're not careful, there will be stigma attached with the disorder, like a mental health disorder. And so that's really become kind of a consistent issue. We consistently are trying to fight against the stigma of these different mental health disorders, right? And it's such a kind of pervasive problems that there are many organizations now kind of that are working toward kind of saying, hey, how come we can't just talk about these different disorders around the table? We need to come out of the darkness. We really need to push against this, like there's something wrong with these different disorders, and really humanizing people. It also gets us into conversations like, why do we diagnose in the first place? Do we diagnose just because we like to label people and we like to kind of, demoralize them in some way? It's like, no, we don't diagnose for that reason. I mean, really the main idea is that when we provide a diagnosis, it should be in order to kind of help guide treatment, right? So in other words, if someone comes in and are, let's say they're struggling with something like a phobia of like like height, like really like if you're standing up on a really high tower or something like that. And they have this huge fear of like being in heights and like they're, oh my gosh, like that's a huge problem. And we go, okay, so do you want to seek treatment for it? And they're like, no, no, not necessarily. And they're like, okay, do you work in a place with lots of like high places, like you're going to be working on skyscrapers or like 10-story building or something like that? They're like, oh no, I don't really go around those places. I don't work with any of those places. And they live in a place like Borger or some small town that really doesn't have a lot of these huge high towers, and they don't have a lot of intention of being around. That's like, well, if we're not going to do any treatment, do we diagnose like, hey, yeah, you have a like, here's your phobia, here's your phobic diagnosis, here you go, like take that home with you? Like, no, I mean, there's no reason to diagnose. There's nothing we're going to treat. There's nothing we're going to do about it. Now, if that person said, yes, I struggle with that, and I work in construction, or I live in a city where there's lots of tall buildings, and I'm constantly in this like this locked up phobic position, then yeah, we diagnose it, because then it helps, that diagnosis helps guide our treatment. It helps us to determine and assess, are we making improvements, what are the areas we need to discuss and address. So again, it's really important for us to understand we don't just do that just so we can like categorize people. We do it for that specific purpose, and oftentimes that diagnosis, once that symptoms have resolved in treatment, we actually pull that off of that. Just like if someone came in to the doctor's office and had the flu, that diagnosis doesn't sit on their chart forever. Eventually, it pulls off as that patient starts to resolve. So that might kind of come off, or they might kind of go from being in depression with in remission, as that depressive symptoms kind of fall off and that person's starting to feel a lot better and we're not having those daily issues. And so again, it's just really important to kind of understand the purpose behind that. So let's get into the different mental health disorders. We're just going to go through kind of some of the biggest categories, beginning with anxiety disorders. Like I said, this is one of our largest categories, and it's something that I kind of deal with on a day-to-day basis. Kind of my bread and butter is working specifically in a clinic where I meet with patients and we talk about kind of what's going on. We talk about their physical health and we talk about their mental health, and we'll kind of discuss like, yeah, it seems like we're struggling with a little bit of anxiety or some mood disorders or those kind of things. And a lot of times it's kind of starting here with understanding what anxiety is, what stress is, and those kind of pieces. So we've already kind of briefly discussed phobia. So what's important to understand about phobia is it's not just I'm afraid of something. It's an irrational fear. It's a fear that is beyond the situation, beyond the actual object that we're around. So it's like where I'm talking with a patient where they have this kind of phobia, this intense fear of like moths, right? And they're trying to go in their house and there's a moth on the screen door, and so they just sit in their car for hours waiting for the moth to leave, because they're afraid if they go up there, the moth is gonna do something, and so again, that in itself, if we think about it, like the moth, can it hurt that person? No, and moths don't generally hurt people, and even if it had some small ability to kind of hurt that person, again, very unlikely. Is it to that extreme? Should that person be hiding in their car? Should they be avoiding even walking up to the front doors of their steps? Right? That's irrational. And we can have lots of kind of different types of phobias. Social phobias. We can have specific animal or environmental or very specific situational types, like flying on an airplane or being in an enclosed space, like a claustrophobia. And so again, you can have kind of these different presentations. And what's really fascinating or interesting here is that with most of these phobias, they're going to create that fight or flight response, right? That kind of increased heart rate, respiration, kind of that adrenaline rushing, kind of like they're in a situation where they have to defend themselves, right? However, there's a specific phobia that you can have, which is a blood type phobia, where when you see blood, it can actually cause you to pass out. And so what's actually really interesting here is that instead of having this like sympathetic nervous system response, we almost have the parasympathetic response where all of a sudden our blood pressure drops so low so quickly that it causes a syncope episode. So what that's called is vasovagal syncope, right? Where we're seeing blood, and then we have this fear response, which then causes our blood pressure to drop so fast that we pass out. And so, especially with these different kinds of disorders, again, it's important to understand, because if it's a blood type disorder, we're going to do more of a tensing exercise where we're kind of shooting the blood pressure back up to prevent the person from passing out. Whereas with a lot of the other ones, we're using these relaxation training exercises to kind of bring that person down and desensitize them toward the feared object. Now, there's going to be a connection here for a moment. If you look right here, we have this disorder of agoraphobia. Kind of agoraphobia, I think, literally kind of translates to something like fear of the gathering or fear of the marketplace kind of idea. And so what this fear is basically like the person's almost afraid to leave their own home, right? They kind of have to be in these places that they know, and when they're outside, they have all these immediate fears that something is going to happen. They're going to be stuck in a car, and they're going to not be able to use the bathroom. They're going to be stuck in a crowded place, and they won't be able to find an exit. So they always kind of have to return home, or they try not to leave home as much as they can. And so getting into this next disorder, this panic disorder, what we see with this is that this person has these kind of sudden episodes where their sympathetic nervous system just fires, right? But there isn't any specific stimulus, right? They're walking down the street, and all of a sudden, like, they have this, like, oh my gosh, everything's about to fall apart. I feel like something's sitting on my chest. I can't take my breath, and there's this sensation that, like, this impending sense of doom that hits them, and it feels awful, right? Most people will end up going to the ER because they think, oh my gosh, I'm having a heart attack, right? And when they go, right, they'll be examined. They'll be the person will come in and check on them, and they'll say, hey, so we don't have any kind of biological specific reasoning for that, other than that's probably a panic episode. You just had a panic attack. And so what the connection here is with our previous disorder, that agoraphobia, is that because these panic episodes come out of the blue, because there's not a specific triggering event that causes them, well, now this person has this avoidant behavior, right? Like, I was walking into Walmart when it happened, so I'm going to try not to go to that Walmart. I was driving in the car on this street when it happened. Now I have to avoid the street, and right. And so we're doing so many avoidant behaviors that we get to avoiding to where we just can't leave our house, right? Which is that agoraphobic, right? So whenever you diagnose something like panic disorder, right? What we also have to say is it with or without agoraphobia, right? Because again, depending on the severity and the longevity of the disorder, it can really create that agoraphobic presentation. All right, getting into the next category here, generalized anxiety disorder. So this one's really interesting because, again, each one of these have their own kind of takes, right? So with generalized anxiety disorder, this person's going to have this pervasive pattern of worry, right? These constant loops of different things that they're concerned about or worried about are floating in their mind. And oftentimes those worries are about things they can't control. They're worried about, well, what if, this person gets into a car accident on the way to work? I'm worried about what if, the weather changes tomorrow. What if, I can't, get this much sleep? And there's this constant worry of it. So many things that are on their mind that there's just this inability to feel like they can relax. They're constantly on edge, unable to turn that off, right? They can't just take that worry and go, you know what, I'm going to switch my mind, think about something else. I'm just stuck in this loop, in this constant pattern of worrying. And so those people end up, struggling with this inability to relax, difficulty concentrating, feeling tense, frightened, fear of losing control. That's actually a very common symptom. This, like, I'm going to go crazy, is what, I'm going to lose my mind, right? That's kind of the fear as part of that. All right, so this next category here of anxiety disorders is what we call kind of obsessive compulsive disorder. So in this one, the diagnosis is kind of in the name, right? So we have these intrusive obsessive thoughts that come into our mind, like of some kind of unwanted event, like, oh my gosh, something bad's going to happen to my family. But it's not just this worry, but it's this intense, like, intrusive thought that like pushes into our mind and we can't stop it. And when it does, we feel this immediate compulsion that I have to do something right this minute in order to prevent that bad thought that just came into our mind. Right? So I feel this compulsion that I have to do this pattern, this ritual, this certain behavior, and I'm going to stop kind of the thoughts that keep coming into my mind. Right, and so sometimes they're connected. Sometimes it's like, oh my gosh, I'm gonna catch some terrible disease, and I'm gonna die, and it's gonna be horrible. And so that person's like compulsions is hand washing. They have to wash it a very specific way, and they have to follow this pattern. And if they don't do it perfectly, they have to go back and do it again, and this constant, all the time, all day doing this. I mean, to increase incredible severity. I mean, to where their skin is so raw and it starts to bleed and it starts to kind of become infected because they're constantly having to do this. Um, but sometimes the compulsions they don't always match the obsessions. Sometimes it's I have this sudden fear that something awful is going to happen to my family, so I have to get out all of my paper money and I have to make sure it has no wrinkles and I have to take an ironing board and iron it. And I can't do anything until it's exactly flat. And once it's perfectly flat, then it's going to be okay. Then I can kind of push back those worries and thoughts, right? And so again, they don't always just line up perfectly, and so it can be kind of very difficult because that person, what's really interesting about this, and this is probably where I'll kind of talk a little bit about some of the differences between personality disorders and disorders, is that this person will walk into my office and they'll tell me like, look, I'm I feel crazy. Like I'm doing these things and I hate it and I don't want to do it and but I have this compulsion. I have to. Like they hate that about themselves, right? Whereas someone with obsessive compulsive personality disorder, this all of a sudden it's not a problem for them, right? They do these kind of compulsive behaviors, these organizing things. Everything has to have to be in fives, or everything has to kind of be facing just to the left by 27 degrees, or whatever it is. But to them, it's comforting. It's the way that they feel normal. But it bothers everyone around. It starts to impact their relationships with their partners, their work. They can't work because they're constantly trying to do these things, and they don't get why everyone else is bothered by it, right? So that's kind of the difference. The term that we use there is some of these symptoms are ego syntonic, and some of these symptoms are ego dystonic. All right, so mental health disorders are ego dystonic. So ego meaning self, and dystonic meaning kind of against or separate or not part of who I am, right? And so, someone with ego dystonic symptoms, like obsessive compulsive disorders, like they don't like it, they hate it, they want this to change, and they want it to stop. Whereas someone who has ego syntonic, kind of these again self centralizing things that they feel like this is comfortable and good for them, they're like, hey, I don't get it, but everyone else around me says some change needs to happen. So, they kind of, that's oftentimes they're brought in for treatment either by a family member or because they're having so many social relational issues as a result. So oftentimes when we look at the causes of these different kind of mental health anxiety disorders, there are some genetic factors. There's not a lot of evidence that shows, that these are 100% genetic or have a very strong genetic link. Overactive autonomic nervous systems, we do see that there does seem to be a little bit of ideas in there, especially when it comes to panic disorder. These kind of like, we have these small sensations that lead to the sympathetic nervous system response, the fight or flight response. Learn to respond to the stress, obviously watching other people, seeing how they respond to those things, and then just inaccurate thoughts about themselves and situations. Now, getting into mood disorders, this is where we're talking about things like depression and bipolar disorder. And so we think about this like on a spectrum. If depression is all the way on this side over here, the kind of unipolar depression, one side, the opposite of depression then is kind of mania. This like instead of everything kind of feels terrible and I can't find any good and those kind of things. Then the other side of that is this like this intense euphoric uprise the feeling where everything I can conquer everything, do everything. But we'll get into that in a moment. Let's just kind of go through and talk a little bit about depression here. With depression, what we see is that we have this depressed system. I mean, really, if you look at the brain images here, you can see depressed versus non-depressed minds. They just become significantly less active, and specifically in the neurotransmitter serotonin. And so, oftentimes, that person will struggle with like fatigue, um, difficulty with either not being able to fall asleep or sleeping too much, loss of appetite, or eating too much. Like it kind of again varies, but it kind of changes their appetite and how they eat, their eating patterns. It impacts their kind of thoughts about the future. Can oftentimes kind of becoming very pessimistic about what things can and can't be in their future. And it's a fairly common mood disorder, depression. Something that we can see that happens, and again, it may be that we do just have a single episode of depression. It's not necessarily recurrent. So we do see this kind of happening and sometimes passing through that person's life. Now, like I said, we have one end, depression, and then on the other far end, that's the mania. This state of elation, this state of intense um, energy. All right, and so oftentimes when someone has a manic episode, they may go 2 or 3 days without sleeping, maybe only sleeping an hour or 2 hours. They have this kind of like their mind racing thoughts is one of the symptoms. So they feel like they're thinking so many thoughts so fast, and they often get really upset at people around them because no one else is keeping up with all the thoughts that they're having, all of the ideas and things, and so and that manic presentation can get to a point of kind of disconnected with reality. All of a sudden, I feel like I can do things that I could never do before. I feel like I can cure cancer, even though I've never had any medical education. I feel like I can, um, you know. I can all of a sudden become this huge, very wealthy person by simply doing this one thing, and I can do it, and so that becomes very um, problematic in that person's life, as they kind of get into a lot of risk taking behaviors, kind of getting into kind of very unhealthy interactions. Um, and so, what bipolar is, if you ever think of that term, bipolar is basically where we will kind of be in this kind of prolonged state of depression, and suddenly we'll shift very hard into a manic state where we're feeling down, we're isolating, we're kind of just to ourselves, we're just, very unmotivated, very, very inactive, and then all of a sudden there's this huge kind of shifting, and now this person is like kind of up for 3 or 4 days at a time, and they're just constantly going, and they're starting 100 projects and not finishing any of them, kind of very manic state, and then they'll shift right back into the depression, right? They'll suddenly just kind of they'll lose all interest. And I say suddenly, I mean they kind of shift and they'll stay there for a while, then they might shift back into a manic episode, a few weeks later, and having another one, you know. Um, and so again, it's very kind of intense. So bipolar 1 is kind of a very strong manic presentation, a hypermania, whereas bipolar 2 is often kind of we didn't necessarily lose touch with reality. We didn't have some of those kind of delusional aspects to the manic presentation, but we did kind of have the sudden upsurge and this very kind of unhelpful or unhealthy kind of manic kind of energy, and then we kind of faded back down. So that's a bipolar 2 type presentation. Now, bipolar disorder is something that is very genetically heritable. It's something that generally we ask about in a medical setting and in a mental health setting. Does anyone in your family struggle with bipolar disorder? Because we do see that there's a likelihood if we have one parent or two parents, or if we have a sibling or even some other relation, aunt or something like that, that will have a presentation or a greater likelihood of developing the disorder. Sorry, that's a better way to say that. All right, so let's move into the next category here: is schizophrenia. So schizophrenia is a mental health disorder that specifically has an impact on that person's cognitive levels of functioning. So we'll start to see this person start to lose touch with reality. So oftentimes they'll have impacts on their speech, where suddenly their speech can become very tangential. So as they're trying to talk to you, they might start talking about this, and they're like, "And I was walking down the street, and there's a fan, and a light, and as there's the bright thing over there, and there's too many lights in the sky, and so I was talking to you about the scarves over there, and there's 5 scarves, and so it's very tangential, or it can be very circumstantial, where you have a conversation, they'll talk about 20 different things, and they'll kind of come back to what you're trying to say, or they'll have a word salad where they'll just kind of throw words that make no sense into the conversation, or they'll be so jarbled with that word salad that we almost can't understand what they're trying to tell us because there's so many different pieces coming in. Then we can have delusions or hallucinations or both. So delusions are where we have some kind of unhelpful or unhealthy thoughts that are just unrealistic. Like, I believe that the person on the radio talking about some hurricane on this part of the world, that was because of me, that they're trying to talk to me, God is trying to tell me something, or these ideas of reference kind of things, or the FBI is after me and they're listening to all my phone calls and those kind of things. Whereas the hallucinations, on the other hand, are where that person thinks they see or hear things or feel things or smell things that are not there, right? Where they will have a sudden activation in the brain where all of a sudden that they hear a voice, or they'll see something happening before them that, again, no one else can see. That's, again, a little bit different than illusions. Oftentimes having kind of emotional withdrawals, very kind of difficult with social relationships, difficulty doing things as simple as dressing themselves because their cognitive functioning kind of starts to decline. Different types of schizophrenia. You can have disorganized schizophrenia, paranoid schizophrenia, catatonic, undifferentiated, and residual. So beginning with disorganized, so this person will often kind of have this incoherent speech, like I showed you earlier, I talked about earlier. Sometimes they'll have this incongruent thought process or mood. So they'll be at a funeral and they'll start laughing and giggling, and but there's nothing that would make them laugh or giggle, or they'll have the opposite. They're at a positive or happy event, they start to cry and feel kind of very emotionally upset. Very kind of difficult for them to complete tasks. Whereas we get into paranoid schizophrenia, it's very much driven by the delusion, right? These people are kind of, like they're feeling persecuted, like these people are after me and all these things are happening, or there's some kind of conspiracy that's going on. Then we have these hallucinations that can kind of present with that. Catatonic schizophrenia is actually very, very rare, but very interesting, where this person will suddenly kind of get stuck in these prone positions, or they'll be stuck in kind of positions where they're just kind of sit in a frozen position for just long, long periods of time, sometimes days, where they won't even kind of move at all, right? And it's like their brain is just kind of like keeping them from, and then all of a sudden they'll move into these kind of very wild, hyperactive, sometimes even like violent, or just like very kind of swinging aggressively, not necessarily to hurt someone, but just because they're suddenly moving and everything else, and they can kind of go back into these states. It's very, very hard, especially when they're kind of going through these. Sometimes they'll have to kind of have someone kind of just to prevent them from hurting themselves, just kind of a restraining thing, just to kind of help them to calm and then they can kind of phase into these different places here. Um, Getting into kind of a little bit more of the understanding that we have with schizophrenia, what we see is that there's a very strong genetic component to schizophrenia, and so we have what's called positive symptoms and negative symptoms, right? So I think of positive, negative as either something is added to you or something's taken away from you. Like your inability to speak clearly is a negative symptom, right? As you're unable to kind of do something you used to be able to do clearly, or your ability to dress yourself in a certain way. That's something that you used to be able to do. And then when you have a positive symptom, that's your added delusions or added hallucinations, things that were kind of added to. And what we see is that oftentimes the positive symptoms are things that are kind of genetically passed down, whereas the negative symptoms are what's happening in the brain as your brain becomes more and more damaged by some of the toxins and just some of the apoptosis, the cell death that's happening in the brain as a result of the disorder. What we do see is that people can have a predisposition to struggle with a mental health disorder, um, with like schizophrenia, but they may never actually develop a full case of schizophrenia. They may have all the predispositions that says that this person should struggle with it, and that presentation doesn't happen. And oftentimes, the disorder kind of kicks off in these very kind of large kind of stressful times or big amounts of adjustment that's happening. Most people will have their first presentations usually when they first go to college or maybe after a major breakup, usually in their kind of late teens, early 20s, kind of having these life-changing events, and all of a sudden they'll have this presentation. What we do see is that sometimes if we don't have some of those moments, some of those big events, that person may never actually develop the symptoms fully. And again, I'm just showing you kind of the genetic heritability. Again, schizophrenia can be very genetically heritable. If we have two family members, two parents with schizophrenia, almost 50% likely that's going to be passed down to the next generation. If we have one sibling or one parent who struggles with schizophrenia, about 17% likelihood that's going to be passed down. And you can kind of just follow the trail there. And again, it does start to damage the brain. You can see the changes in the size of the ventricles here, meaning that there's been a lot of cell death that's happening, and therefore there's less brain mass, and as a result, there's less ability to cognitively function. Personality disorders. So this is, again, kind of the difference here is this kind of very these symptoms that can be very kind of egocentric, that make sense to them. That's how they live. That's how they think. But it doesn't necessarily societally make sense, and it can be very maladaptive, be really unhealthy, unhelpful thought processes, very inflexible thinking patterns that can happen with these disorders. So beginning with the first one here is this antisocial personality disorder. So with this one, oftentimes, when we think of antisocial personality disorder, you probably heard of someone they talk about someone as a psychopath or a psychopathy. This person kind of has this lack of that moral compass. Where someone else might feel guilty about something that they did. Whether it's to hurt someone else, take something from someone else. People who struggle with antisocial personality don't have that same kind of conscious, right? They don't feel guilty for doing something, or they don't feel like they need to make it up to someone else if they hurt them in some way. So oftentimes these people can, because they're going to struggle with that, they kind of get more kind of involved in deceptive type behaviors, con artists, right, where someone is intentionally trying to trick someone else out of their money, and this, and again, because it's like, why do I need to follow societal rules? Like, I don't believe that those rules need to apply to me, and so as a result, kind of they often will just kind of go against what other people might tell them to do, and that can become very problematic in their lives and the lives of the people around them. borderline personality disorder. With this one, this is kind of like the I almost call it like someone with a very sensitive emotional skin. It seems like everything is kind of everything that happens. It seems like it happens on a bigger level to them, and so this person will generally have like very volatile relationships. You know, they meet someone for the first time, and that they're their best friend. They're like the greatest person in the world, and then they say something that's not just right, and all of a sudden they're the worst person in the world, and I hate you, and we have no connection. Like we're not. Um, like we can't be around each other. Oftentimes, that person talks about just feeling often alone. They feel empty. They feel like everyone in their life just kind of hates them. And so, in order to kind of get those relationships back, because again, if they're very volatile in these relationships, their own family members sometimes have difficulty kind of adjusting to that. And so as a result, they will kind of resort to more and more extreme measures to kind of get those people to sympathize with them. Like, look, I'm feeling these huge emotions, and you need to understand that. And if you don't understand that, then they might even attempt to hurt themselves, and oftentimes will make a lot of threats that they're going to end their life, and sometimes they'll even go to greater extremes. And each time they go further and further, and they start to actually hurt themselves and start to attempt in their lives. And so as a result, they have so many attempts in life sometimes that the extreme measures they go to, that it does get to a point where they do fully commit suicide. And that's really hard. It's really hard condition to work with, very difficult to make progress in therapy with this disorder. Narcissistic personality disorder, and this person has this kind of exaggerated sense of importance, like I'm the most important thing. And so whenever someone else interferes with what they're doing, they're like how dare they, like I'm the only most important thing here. And so if people aren't like doing something special to treat them, then they feel like, oh my gosh, like I need to like walk over that person. I need to like push them down and show them who should be in this place. And they don't have that sense of empathy. They can't like understand like why someone else have different emotion. It's not theirs, so they don't care about it. And that creates a very difficult thing. Oftentimes, we'll see people with like dependent personality disorder and narcissistic personality disorder kind of come together, and that's a very, very unhealthy relationship, because that dependent personality disorder, they feel like they have this intense need to constantly be in a relationship and be around other people and try to like if they're not in that relationship, there's something wrong. And so those people with narcissistic personality are like, well, they're just kind of worshiping me as I should be, kind of thing. And it can be very unhealthy. Um, we've talked about some of these other disorders. We've already kind of talked about substance use disorders and attention deficit. We talked a little bit about kind of eating disorders and some of the different kinds here, sexual disorders we've talked a little bit about, and some of the kind of organic mental disorders. Now, what I've done is I've collected just a lot of different kind of infographics to show you kind of the different levels of these different mental health disorders in different parts of the world. And these are something you can look at on your own time. I just think it's really interesting to see kind of, where we see these symptoms present most of the time, and what parts of the population, and more men and women, and what time and age is it onset. Just things that I think is really good and important for y'all to kind of review and look at. It's been great to get to talk with y'all. I hope you have a good week and weekend, and we'll catch you next time.